So first of all, in terms of talking about spinal and epidural anesthesia, it's very important to understand the anatomy of both the spinal cord and the epidural space. So as a reminder from your anatomy classes in medical school, the spinal cord itself terminates at the conus medullaris, as you can see on this slide here. Now, usually that conus medullaris will terminate at about the L1 level. So if you were, for instance, doing an epidural in the lower lumbar region, even if you did get a dreaded wet tap, you should be far away from hitting the spinal cord. It is important, though, to understand that the termination at which the conus medullaris terminates does vary from patient to patient. And can extend down as far as L2 in some adult patients. And it does generally extend lower in pediatric infant patients, can go down as low as L3. Now, also within the subarachnoid space, in addition to the spinal cord, there's, of course, cerebrospinal fluid, and also down lower in the lumbar area, you will find the cauda equina, which is essentially the lower lumbar and sacral spinal nerve roots. So that will lie within the subarachnoid space also. In terms of doing your procedure, let's take a look at this picture, which I think is a lot easier to be able to visualize where you're going with your epidural or your spinal needle. So you will first, as you palpate the inner spaces, decide what level you want to go at based on what you're doing the epidural or spinal for. And you will first, your needle will first identify the supraspinous ligament, as you can see in this picture. As you advance further, you will approach the interspinous ligament, and finally the ligamentum flavum, which is the last structure before your needle will enter into the epidural space. You will know that you're in the epidural space by a loss of resistance when you're doing an epidural, because when your needle is within those overlying ligaments, you will have resistance as you push on the syringe of your, on the hub of your syringe. Once you enter the epidural space, when you push on the plunger of your syringe that's hooked to your epidural needle, you will get a loss of resistance. Now, when you're doing a spinal anesthetic, you're not using a loss of resistance technique. You are essentially advancing the needle until you feel what you think is a pop. Whenever you feel that change, you will check to see if you have spinal fluid, because as you look at your anatomy here, that spinal needle also is going to go through the overlying ligaments and then into the epidural space. And sometimes you will feel a pop as you go into the epidural space, but if you take the introducer of your spinal needle out and find that there's no fluid coming back, you know you have not yet reached the subarachnoid space. But the most definitive pop that you would generally feel is when you puncture through the dura, which is right beyond your epidural space. And then you should have entered the subarachnoid space, which you will identify by seeing that there is spinal fluid coming out through your spinal needle. And occasionally when you're doing an epidural, you also puncture that dura and you might see spinal fluid coming out through your large epidural needle, that dreaded wet tap, which we will all have at some point in our career. As I tell residents, when you get that first wet tap, don't feel bad. If you haven't had a wet tap, I tell every resident, that just means you have not done enough epidurals. So that's sort of an overview of the anatomy to be thinking about when you're doing these procedures. Now, once you have achieved your epidural or spinal block, you need to understand where your level's at. And in fact, in terms of dosing a spinal or epidural, you need to understand what sort of sensory level you need to have adequate anesthesia or analgesia for whatever procedure the patient is undergoing. And this is a nice dermatomal map that you can keep with you to remind you of such things. Some easy things to remember is that the umbilicus is at T10. The breasts are at like T4, below the breasts, T6. Those are some nice landmarks to remember in terms of identifying where your level is at. But I think, as you get used to doing neuraxial blocks, it's probably a good idea to keep a copy of this dermatomal map with you so you can figure out what level your block is at as you check for a sensory level. Now, how do spinals and epidurals work? Well, essentially what's happening is that you are injecting local anesthetic into either the epidural or spinal space, and that local anesthetic disrupts the nerve transmission. The site of your neural blockade is going to occur at two places, at the spinal cord itself and also at the spinal nerve roots that are present within both the subarachnoid and epidural spaces. Now, it's important to understand there's different types of nerve fibers, and their sensitivity to the local anesthetic that you inject vary based on the size and the myelination of those different types of nerve fibers. So, important to understand the order of sensitivity. So, your preganglionic sympathetic fibers are going to be most sensitive to local anesthetic, followed by the sensory C fibers, which essentially provides temperature sensation. Next is going to be the sensory A delta fibers, which is pinprick or sharp sensation, followed by the last type of sensory fibers, which is the sensory A beta fibers, which is the touch sensation. And the least sensitive of all those various nerve fibers is your motor A alpha fibers. So what does this mean in terms of sensitivity? It means that when you do a neuraxial procedure, there is going to be a differential block, meaning that certain nerve fibers you're going to have a higher level. So your highest level is going to be that of your sympathetic block and your anesthesia to cold sensation. Approximately 2 dermatomes lower is where you will have anesthesia to pinprick. And then finally, about 1 or 2 dermatomes lower is where you will have anesthesia to touch sensation. Now, this is important to know, especially when you are checking your sensory level. For instance, many people like to check their level based on using cold. They don't like sticking a patient with a needle, and that is fine as long as you understand that, for instance, if you have a block to T6 for cold, then your block to pinprick to sharp, which is what you really need if a patient's undergoing surgery, is going to be a couple dermatomes lower, like T8. So that's important to know. And then touch sensation will be lower than that. So as you practice, you'll decide whether or not you want to check your level based on pinprick. That's what I like to do. I just like to know if I'm doing surgery with a spinal or epidural block that the patient does have good anesthesia to sharp, because that's what they really don't want to feel when the surgeon starts the surgery. But there are many people, like I said, that like to check to cold sensation, and that is fine, just understanding that your level for cold sensation is going to be higher than the level that you have for sharp sensation. Now let's talk about some of the physiologic effects of neuraxial blockade. So first of all, the degree of changes, of course, is going to be related to the level of the block. Particularly, your sympathetic block. If it's a T4 sympathetic block, you're going to have greater degrees of cardiovascular changes than if your level to sympathetic block is T8 or T10. So what happens cardiovascularly? So when you have a neuraxial block, you will have both venous and arterial vasodilation occurring. However, it's important to understand that the venodilation predominates in terms of that vasodilation, leading to primarily a decrease in venous return and then ultimately a decrease in stroke volume. Now, heart rate will also be affected with your sympathetic block when you have a high level. The cardio accelerator fibers exist at the T1 to T4 level. So if you have a sympathetic block going up to the high thoracic levels, T1 to T4, then you will generally see a decrease in your heart rate with unopposed parasympathetic activity so that you can see significant bradycardia with high neuraxial block levels. What about cardiac output? Actually, there is generally a biphasic effect on cardiac output. Initially, the decline in systemic vascular resistance resulting from arterial vasodilation will occur more rapidly than the venodilation. So initially, for a brief period of time, due to that more rapid decrease in SVR as opposed to decrease in venous return, you may see a small increase in cardiac output. This is especially the case in elderly patients who have high SVRs and have long-standing hypertension. However, soon after, as the venodilation, the decreased venous return catches up with that decrease in SVR and actually becomes more predominant in terms of the vasodilation that's going on, you'll see generally a mild decrease in cardiac output. It would be unusual to see a marked decrease in cardiac output in most patients who have a neuraxial block. What about respiratory changes? In most of our patients, the respiratory changes resulting from neuraxial block are really of minimal clinical consequence. Now, there is a decrease in vital capacity due to a reduction in expiratory reserve volume, which is related to the paralysis of abdominal muscles. Because remember, although we're mostly interested in our sensory block, we do get a motor block also. And the abdominal muscles are skeletal muscle. You will have blockage of the abdominal muscles with your block. And in fact, when you're doing abdominal surgery under neuraxial anesthesia, you need that abdominal muscle paralysis to aid the surgeons in performing their abdominal surgery. However, the blockade of the intercostal and abdominal muscles that can occur with a neuraxial block will generally not adversely affect respiratory effort. Essentially, the diaphragm and other accessory respiratory muscles will not be affected by your neuraxial block. It'll be primarily your intercostal and abdominal muscles that will be blocked. It's important to understand, though, I said in most of our patients it will be of little clinical consequence. However, if you have a patient with severe respiratory disease, someone with severe COPD, for instance, those patients may rely quite significantly on their intercostal and abdominal muscles to help them with their breathing. And when you have a motor block that involves those abdominal muscles, it may make respiration problematic for that patient. So that's something to be cognizant of when you are doing neuraxial block in patients with serious respiratory disease. And one thing that I do in some of these patients, if I am considering doing neuraxial block, is I don't do something like a single shot spinal. Instead, I may do an epidural or a continuous spinal and just slowly raise up the level and see how they do as those abdominal muscles become blocked, and see if they are going to tolerate that blockage. And if they are showing signs of respiratory compromise, then you may not be able to proceed with neuraxial blockade in patients with serious respiratory disease, and you might have to convert to general anesthesia. And in some patients with severe respiratory disease, you may decide ahead of time that this patient is not going to tolerate affecting their respiratory, their abdominal and intercostal muscles. Blockage of that is going to compromise the respiratory status to a point that you will decide neuraxial anesthesia is not the best option in this patient and instead may need to have a general anesthetic. Now, you may have heard that when someone gets a higher total spinal, you actually see a respiratory arrest. One thing to understand about that in terms of the physiology of a respiratory arrest associated with a high spinal is that that respiratory arrest does not result from intrinsic respiratory dysfunction. Instead, it results from hypoperfusion of the respiratory center of the brainstem. That is the etiology of the respiratory arrest that you will see with a high or total spinal anesthetic. To review, the primary factors affecting the block height with a spinal are, again, the local anesthetic dose, but then the baricity of the local anesthetic and the patient's position. Now, we've talked about the factors that are going to affect the level that you achieve for your spinal or epidural block. Next, you need to think about what's going to affect your block duration, because the last thing you want to do is to, for instance, do a single shot spinal and then not have the block last sufficiently long enough for the surgery to be completed. So the primary factors affecting your block duration are going to, again, include the dose of local anesthetic, but also the type of local anesthetic. Some local anesthetics have a longer duration of action than others. For instance, the duration of action of bupivacaine is going to be longer than the duration of action of lidocaine or chlorprocaine administered epidurally. Another thing that you can do to prolong the duration of an epidural or spinal block is to add other drugs to your local anesthetic. That includes vasoconstrictors such as epinephrine, which will prolong the duration of your block. The addition of an alpha agonist, such as clonidine, will also prolong the duration of your block. You need to understand, though, that if you add an alpha agonist to your epidural or spinal block, it will also generally give you a higher degree of hypotension than if you did not add it. Also understand that these additive drugs have a much greater effect when they are added to spinal local anesthetic than with epidural local anesthetic. You don't see nearly the effect of these additive drugs when doing an epidural procedure as compared to a spinal procedure. Okay, now that we have talked about the factors affecting your block, the physiology and such, let's move on to the complications, because as you know, with any procedure, there can be complications involved. So most common complication probably would be that of hypotension. Makes sense, as we said, in terms of the physiologic effects of both spinal and epidural anesthesia. You have vasodilation, you have decrease in venous return, decrease in SVR, so you can see hypotension. The higher your level, generally the higher the degree of hypotension. With a high enough level that in fact affects those cardioaccelerator fibers, nerve fibers, at levels T1 to T4, you can also see bradycardia result from that. Post-dural puncture headache, also known as spinal headache. This is one of the complications that we can see, and it's important to understand that this can happen with any dural puncture. So although you mostly think about spinal headache when you talk about that dreaded wet tap with an epidural, you can see a spinal headache with a spinal puncture with a small non-cutting spinal needle also. Post-dural puncture headache is going to be a positional headache. And just, to know that everyone at some point is going to have a wet tap, which if you have a wet tap with an epidural needle, a 17 or 18 gauge epidural needle, you will have at least a 50% chance of developing that post-dural puncture headache. Don't feel bad when that happens. As I tell residents, everyone who does neuraxial procedures is going to have an epidural wet tap at some point in their training or career. And when a resident tells me that was my first wet tap, I tell them, well, you just had not done enough epidurals beforehand. Everyone will have wet taps. Don't feel bad when it happens. But as I said, even the patient who has a spinal anesthetic performed with a 25 or 26 gauge non-cutting spinal needle can have a risk of developing a spinal headache, but now the risk is going to be 1% or less as opposed to 50% or more. An epidural hematoma can occur, and with that, if you develop a hematoma within the epidural space, you will get compression of the nerve roots within the epidural space that can lead to long-term neurologic deficits. So this complication needs to be identified very quickly and the hematoma evacuated to prevent long-term complications. Obviously, this would be most common in a patient with some sort of coagulopathy. Infection is another concern. Epidural abscess and meningitis, those things can occur with an epidural abscess, just like with an epidural hematoma. If the diagnosis is made, it needs to be evacuated very quickly, so again, it does not cause long-term neurologic deficits due to compression of the nerve roots by that abscess. Meningitis can be life-threatening, and in fact, there have been case reports of patients dying after spinal anesthetic due to developing meningitis associated with the spinal procedure. There have actually been case reports where they have been able to do DNA typing of the bug that caused the meningitis, and then also looked at the flora in the provider's mouth or nose and found that it was the very same bacteria. So obviously wearing a mask is very important, and just very tight aseptic technique for any of these neuraxial procedures is important to prevent that complication of infection. Urinary retention is another complication we can see with neuraxial anesthesia. And with spinal only, you can see transient neurologic symptoms. This is a syndrome that's kind of unique. It occurs most commonly with spinal lidocaine, but can occur with any spinal local anesthetic. And essentially, this develops 24 hours or later after the spinal block has resolved. And the patient essentially presents with severe buttocks pain, most commonly radiating into the legs. Also, it's important to note that it is pain only. There are not going to be any neurologic deficits such as motor weakness or sensory deficits. It is clearly pain only, and it will resolve on its own within a week. And then in terms of epidural block, you can have intravascular injection if the epidural veins are present, and if you thread your epidural catheter into an epidural vein and then inject local anesthetic intravascularly, you can develop local anesthetic toxicity with a large enough dose. You also can have a subdural injection of local anesthetic with an epidural procedure. So the subdural space is a potential space, and generally you'll see a subdural occur when it's been a traumatic or difficult epidural placement, that the catheter may go subdural. Identifying a subdural block, typically what you will see as opposed to an epidural, the block is really significantly different than what you would expect with an epidural block. So with a subdural injection, subdural block, you would generally see a higher sensory level than you would expect based on the level at which you perform the epidural and the dose of local anesthetic that you used. You're more commonly going to see significant hypotension with a subdural block, but also you generally will not see the degree of motor block that you generally expect. You'll usually see less motor block, and you oftentimes will have a patchy block. So those are the important complications of spinal and epidural anesthesia. And now that you've had a chance to review this podcast, when we meet on Wednesday afternoon, we'll have time for all of you to use our task simulators to practice doing both spinal and epidural procedures. Thank you.